Hey, Daniel, how's it going?
Hey, Evan. It's been a busy week. I got asked right before the podcast, like, what am I doing this weekend? And I have legitimately no clue. So maybe that's a good thing. Maybe I can relax and catch up on life. How are you doing?
I'm doing okay. I wish I could say the same. It is officially Girl Scout cookie season. So now somehow was roped into work cookie booths all weekend. So um, for those Oregon listeners, well, it should be past when I was at a booth. But yeah, for anybody in Oregon or Southwest Washington, get your Girl Scout cookies all the way up till the end of March. So this will drop, I think, in March. So
What's the best cookie?
you know what? They're regionalized. So this is the interesting part. So like your cookies come from on the East Coast come from a different co-packing facility. So even like a Thin Mint is made completely different. So on the West Coast, it's a chocolate wafer cookie with mint baked into it and then chocolate mint frosting on top of it. But in Texas, it is a chocolate chip cookie with mint chocolate frosting on top of it. So like they even do it, and it's like they're called caramel something on the East Coast, but they're well known on the West Coast as Samoas. So it is very interesting the type. East Coast also has one this year. Our Matt's cousin's daughter is a Girl Scout as well, and he got French toast cookies. We don't have those on the West Coast this year, but they're okay. They're not the greatest. My favorite cookie though is probably a Thin Mint because I like to put them in the freezer and have them frozen when you eat them. But yeah, that there is your Girl Scout cookie information, everybody.
Maybe we'll have to do a whole podcast segment, bring all the Girl Scouts on. Uh,
I would be worried what they would say. It's a bunch of like 10 and 11-year-olds. So
you want to
well,
introduce today's topic?
yeah. So today we are diving in a little bit more into all the CMS world of what's happening in the debate section with some new publications of the rules. We're also going to kind of just learn about how to potentially hold some payers accountable and what's kind of starting to happen in some of the struggles. It's kind of nice. We got a little bit of a mix of business partner and provider on today, so I think it'll be a kind of a good little segue for us for future segments too.
Cool. I think we're still working on titles for today's podcast, but looking forward to what comes through. Unless I see pricing transparency, maybe that's what we'll call it. But I'll go ahead and introduce our first guest today, just to jump into the podcast, get us rolling. Or might be a little short on time. We're going. We had a little bit of a chat beforehand about Evan's wine situation, so I'll have to regale that for listeners another time. So our first guest worked in the revenue cycle industry for 16 years, or not worked, has worked or is working. Has a unique experience as a thought leader by pairing her love of project management and lean processes with the complexities of healthcare finance. Also a member of the Oregon HFMA chapter, like Evan, and I'm assuming you all are both in that chapter together, and is the Operations and Facilities Committee Chair. Currently the Director of Revenue Integrity at Oregon Health and Sciences University. Welcome, Aundria. Thanks for joining the podcast.
Thank you so much, Evan and Daniel. Looking forward to speaking with you.
Yeah, me too. Well, I got to introduce our second guest. They're pioneer in patient estimates as the former founder, I guess, or original founder of FHS Corp. Also has co-founded several other things and is kind of a industry thought leader as well in healthcare. Really pioneered and is the current CEO of Hyve Health. I get to call him dear friend and a colleague. I've been able to partner with him when I was a provider as a business partner and maintained a relationship going forward. So welcome, Travis, to the podcast.
Thank you. Appreciate it very much. Great to be here.
All right. One of the hot topics we wanted to discuss today was provider education. I know Evan kicked us off a little bit with a summary there. And Travis,
typo, actually, Daniel. That's my bad. Sorry, we're jumping into payer accountability.
Oh my goodness. It's in the It's right here. Yeah, we're
Yeah,
developing payer
it's an Evan
scorecards.
error, everybody. I screwed up on our call sheet.
We're gonna pivot here. So no provider education. I think we talked about that another day. I was like, what's going on here? But Travis, you're working on developing payer scorecards. I know I was digging around y'all's website over at Hyve Health, and there's a lot of cool work you're doing. And I was just hoping you could share with us just like what comes to mind when you think payer scorecard, and what are the cool innovations that your team's doing?
Thanks for asking. I think there's a lot of kind of turmoil in the industry that's coming out of payer behavior. I mean, a lot of it stems from Medicare Advantage plans. Historically, we've had all these issues just even with the commercial payers. And at the end of the day, right, a hospital has their experience with a given payer, but they don't really understand if their experience is better or worse than their peers. And the concept of payer scorecard has been talked about in our industry for years, probably well over even a decade. And we just had this idea that says, well, what if we could go get every claim, every remit from every hospital in the country? I know I'm riding a unicorn as I say that, but but it's better to saying like, can we get a collective aggregate experience from all of the hospitals to be able to get quantitative data to hold payers accountable? The payers have the data, the hospitals don't, and hospitals need some ammunition to be able to push back and hold them accountable.
What are some key metrics that you think really should live in a payer scorecard, or that you're really focused on when talking with clients?
I think for us, it's kind of boiled down to about 3 different areas. One is around how prompt payments are, and being able to measure that speed, or really it's more of the delay in payments from the time that a claim has been submitted by the time that a clean claim has been paid, let alone the time that it takes to reconcile denials and how much that slows down payment. There's another area where we get into reimbursement and trying to help providers understand if their reimbursement relative to their peers by that payer within that state, how competitive that is. And that can kind of dovetail into some of the price transparency stuff we can talk about. And then ultimately, I think the biggest cornerstone of all that is denials, right? And being able to understand that, hey, it's great that I've made progress in going from 12% to 10% to 8% in my denials over time. But what if the rest of the state, is at 6%, right? It's a matter of trying to understand what good is and understand what I call the me versus the we. Is this a problem that's unique to my provider, or is it something systemic that all of us are experiencing?
I think that leads us, a great segue for Aundria to jump in here too. So what are tools and solutions that, OHSU is trying to leverage right now, or we know our other peers through, connecting through HFMA and other avenues are using to kind of manage their payers, while other companies like Hyve and even Epic to some extent are trying to build out these different payer scorecards?
Thank you, Evan. Yes, it's such a delicate balance, right? We have a relationship with all of our payers, and so we certainly need to work together as a team. So I think obviously the first lever that we always want to pull is reconnecting those relationships, whether it's at the revenue cycle leadership level, where we have monthly meetings with some of our biggest payers, where we can really get down to the weeds of what exactly is happening at the claim level. I think aside from that, though, really leveraging our managed care contracting department and working closely in a partnership so that we can feed them the data that supports, the need to push back on the contract. One of the things that we've done at OHSU is we actually developed our own payer scorecard. Tammy Bickle, who is our director of professional billing and coding, really pioneered that. And while we don't get to compare to any of the other organizations, Travis, I want to ride that unicorn with you. We do get to compare the payers to each other within our health system. And so we created a dashboard that can be sorted and filtered. It all pulls in our EHR data, But then we can really show departments, here's how this one payer compares to another, for example, or here's how one CCO plan in Oregon compares to another, both with, AR or over 90, all of those KPIs that Travis had mentioned. And I think having that kind of a leverage to say, we can play this game too, and we want to work with you, but here's the data that supports it.
I think it's really cool too, just for our listeners who might not be using Epic yet or coming on to an Epic EMR type system. Even in their denials dashboard now, they've allowed you to have a drop down for your top 10, I think it is, payers, and be able to select those payers to see what those denial drivers are in comparison to your automation as well. So if you notice like your coding denials are happening, have gone up, but you're also, 60% coded automation, you might need to drive in and see, like, is it, is it a design flaw that's yours? Like going back to Travis's point, is it unique to you versus being unique to the industry with that payer? Because it could be, some of that automation work that's taking place as well.
Yeah, I hear, Aundria, you're talking about like what OHSU is doing, and I hear the words relationship, I hear the words partnership. What I don't hear is accountability, and I'm curious just for both of you, both y'all's thoughts on like accountability and as health professionals, whether we're partnering with organizations or we are the organization. What are some of the tools and tricks of the trade that we're seeing for accountability?
Travis, I'll let you answer that first. I think we've got a couple different.
I think to have accountability, right, and a good relationship means that, that providers and payers can come to the table and have an honest conversation. I think historically, the anecdotal stories from the providers will be that they're bringing stories, they're bringing cases of which a lot of the times kind of gets turned because it's just what I call the little Johnny claim story, and there's not a lot of empirical evidence to always back up the story. And so, in order to have the accountability in the relationship, right, is that the providers today have all this data and they tend to leverage that in the conversations with the providers, where the providers, always have their data, right, and they're creating their own payer scorecards, but then they lack that context of the me versus the we that says, is this just a me problem or is it a we problem? Well, the accountability now for the payers is not just to understand what is happening between that provider and that payer, but it's really to step back and hold payers accountable across the spectrum to be able to say, well, not only payer A are we having this problem with you, but as we look across the spectrum of all payers within a given state, you're actually, the slowest to pay or have the highest denials. That's an accountability level that doesn't exist today.
Really, really good point. I think, back to managed care contracting, it's so vital that we hold our payers accountable. They have a responsibility to our patients and they have a responsibility to us as providers. And I think one of the tools that OHSU, a pretty big lever that we've pulled recently is during a renewal period saying, we're not actually sure if you're meeting our needs or your patient's needs. And so we are not going to re-sign with you. And I think sending that message to patients, it's shocking, right? It comes as a huge surprise and it definitely causes a lot of angst, I think, for patients. However, it's our responsibility to share with patients that your payer is not actually helping you be a healthier human.
Well, and I think what's key there, Aundria, is what you said is that your payer is not providing you the service that they should be, so that we can then provide you the care that you need. I think, it's interesting living in the Northwest. I just got a letter from another health system that I happen to be going to, and saying that my primary care provider and my specialist will be out of network potentially in March with a large payer who shall not be named. And with that alone, I'm like, well, that doesn't work for me because I can't get in for my treatment. I can't get in for this. And initially, as a patient, you say, okay, health system, you need to fix this. But really, it's, hey, payer, you need to come to the table and make sure that you're getting the right reimbursement rates, and that I'm paying you these large premiums and everything. And yet I need this service. And you're doing me a disjustice of not getting me a continuation in care, whether we look at like the vulnerable patients as cancer, transplant, the high risk patients, but really any patient, because I shopped around for a long time to find my primary care provider, somebody who I trusted to give me guidance and give me and understand who I am, and that portion. And we fail to recognize that really the payers not coming to the table and saying, hey, let's make sure we're paying and we're doing this timely and we're processing things so that health systems can maintain their doors open. It is where we run into a lot of issues. So leading into that, where do you guys think that we're going to go with both federal and state requirements holding payers accountable? And this is kind of teeing us up, into our next segment around pricing transparency. But taking that portion off the table, what are some of those things that we really need to be leveraging our lobbyists to be pushing back on payers to see how we can get better improvement with healthcare?
I think at the federal level, I think it's going to start with Medicare Advantage, because we've got some recent regulations and rules coming out of CMS about what the commercial payers are supposed to be doing with their MA plans. I think there still lacks this transparency of how does a commercial payer offer up this MA plan, and those MA plans tend to be more aligned with the commercial denial methodologies. And at the end of the day, you're saying, look, this was a Medicare patient that is now on a Medicare Advantage plan, and everyone is expecting, the same level of service as a patient, right? When we see increased denials, that Medicare patient now is not getting the same service as they were when they were on Medicare. But then at the same time, the provider, right, we're starting to see that the payments are slower, the denials are more for Medicare Advantage patients. And so that level of accountability nationally has to be applied. And then I think as that ripples through at the state level, because I think a lot of the advocacy and this accountability actually happens more at the state level than it does at the federal level. And we're even starting to see, because there's still certain states that don't even have managed Medicaid, right? And there's the same fear and an angst that exists in going from a Medicaid fee-for-service to a managed Medicaid that is going to be, the same story that they're experiencing with Medicare and Medicare Advantage. So I think that's going to be a couple different tiers. And to me, it's all about providing the information that allows them to hold accountable, right? We have the anecdotal stories. Now we need the empirical evidence to back it up.
Yeah. Maybe just put a quick thought into that. Just like from my experience, I'm working as a revenue integrity director, but I have an IT background, and we're seeing all sorts of denials from our managed care programs. And I'm like, it's really hard when they don't all operate the same way. I'm just like thinking about, like, from a system perspective, how complex it is to identify all the differences and put those requests into the system. It's like really hard for like an IT program to differentiate between all these and operations to identify all the scenarios. And it's really nice when there's just like here's like CMS Medicare guidelines and this is how things work. But when you jump into all the complexities and nuances of different payers, it's like reading 100 different playbooks. I don't know, just my soapbox for the day. Really frustrates me.
Well, and if I could reply to that, I think the reason is because we don't have a normalized view of that, right? Like you take denial codes, right? We have all these CARC and the RARC codes. We have a national normalized set of codes, but that set of codes for payer A, right, is being deployed and adjudicated differently than payer B. And it creates, to your point, all these 100 different playbooks of like, how do I deal with this denial when I'm focused on payer A and I have to address it differently with payer B? And it's back to this accountability that says all of these codes should be adjudicated the exact same way. But if I don't have a normalized view to look at them in an apples to apples, environment, then that's what allows all these playbooks to become their own story instead of saying, here's a common set of rules. And we're actually now able to see and to articulate, the same codes and how they're deployed by payer. And it is as unique it is by payer. So that's how you can start holding them accountable, because you can show them exactly how, those denials are different.
Let's take a quick break and we'll be right back.
There are thousands of medical offices and facilities across America, each navigating through changing regulations and reimbursement models while striving for positive patient experiences and outcomes. A common element in each of these facilities is patient access, the front line of both the revenue cycle and the patient experience. Though diverse in facility size and geography, patient access professionals unite around a common purpose: enhancing the overall patient experience to increase patient satisfaction and outcomes. Through it all, one organization is there to educate, connect, inform, and pave the way toward the future of patient access. The National Association of Healthcare Access Management recognizes the changing role of patient access professionals and their increased importance.
Claim Capital is a team of ex-Epic staff focused on preventing denials. Instead of showing what was denied, which is the standard for other solutions available today, Claim Capital pinpoints why claims are denied. By training machine learning models on an organization's claim and remittance data, Claim Capital can identify the causes of denials and recommend changes in EHR build or workflows to prevent them from happening in the future. With a completely HIPAA-compliant infrastructure, no software implementations, and a zero-risk pricing structure, organizations can quickly and safely recover lost revenue.
And we're back.
All right. So let's move into the debate section, the horror that keeps us up at night, pricing transparency, which I feel like we've talked about price transparency, maybe a good light before. Maybe we're going to talk about it in a bad light today. I don't know. We'll see where the conversation goes. But we'll be discussing industry trends, out-of-the-box ideas, topics related to pricing transparency. Evan, you want to kick us off today?
Yeah, so I think going with that horror, I think it is like the CMS has definitely updated the regulations. We have a ton of new things coming and going to be facing big challenges. And, we just wanted to get both of you guys' perspectives on, with just a few months away, what are some of those big challenges that health systems are currently facing and trying to tackle? And I'll let whoever wants to jump in first and go, but you guys feel free to talk over each other. It makes it a little more fun too.
Thank you. I'll jump in here. This new requirement that starts 7/1 of 2024, this is what keeps me up at night. And I think there's a lot of things that could keep you up at night in revenue cycle. But I think, getting this right is very challenging for organizations. Number one, because of the inordinate level of the file sizes. Right? We can't even open these files anymore on regular computers, and that's definitely been an issue at OHSU. But the level of scrutiny that is required within your contracts, that's the piece, that's the link that has been missing from the pricing transparency chain. We aren't just asking anymore for your top 10 payers or even your top 20 payers and an average of their pricing. Right? We want every single price that will ever be spelled out in a contract, and we need that shared in a public way so that it is a machine readable file for payers and providers alike. And I think that definitely will keep us all up at night past 7/1.
Yeah, I think, the way that the industry kind of replied or responded to the initial regulations, right? There was this spectrum or this continuum of, am I trying to be as a provider transparent to am I trying to be compliant? And somewhere in between is probably the reality for each of the providers in terms of their strategy and how they replied, the different technologies and approaches. And I think everyone started to get comfortable with the game that was being played. And I think people thought, okay, some new regulations were coming out. And the reality is that the game changed, and I think that the level of transparency has increased and it has shifted, for providers to easily articulate how they're getting reimbursed is difficult to begin with, just in terms of day-to-day business, right? Just trying to understand, did I get paid correctly on a claim, and did I get underpaid? Let alone to be able to translate that in such a way that can be normalized and put into the machine readable file with this, this theory that these files are going to be able to articulate nuances from provider to provider in terms of how they're getting paid, is drastically different than what we were doing over the last 3 years, right? And to introduce this concept of methodology, it's one thing to say, hey, Blue Cross Blue Shield, HMO, colonoscopy, 45378, $1,200, right? I kind of use like the analogy that's the answer. And now I feel like we're going back to high school math class where they're saying, well, I need you to show your work. How did you get to that $1,200? And I think that has completely changed the game.
So Travis, let me ask you a question, because that's such a great point. That fuzzy math that we remember from Al Gore. I feel like when we talk about pricing transparency, we're not necessarily talking about the public, right? We're not necessarily saying, Bob over here wants to log into OHSU's website and check out all of the prices that could possibly happen in and around a colonoscopy, because Bob can't actually open that file at all. It's actually probably not possible for him to do so. And so I think there's some misinterpretations maybe by the public that this is somehow giving them more of those tools that you just spoke about. In your area of business, Travis, we're really looking at vendors as the solution. And I'm just wondering, from your expertise, what would you kind of tell an organization like mine? How would you go about getting this done in the next few months?
Our approach, right? I mean, historically, we were looking at, claims and remit data and trying to be able to extrapolate out of there what reimbursement was, looking at charge masters and aggregating all that together. And now it really is forcing these hospitals to crack out their payer, contracts and open those up and dive into that and be able to extrapolate that, of which some of them may have done that in some way, shape, or form. But oftentimes when they model it, right, they're modeling what the answer is, and they're not capturing this methodology. And so to your point, when there's this expectation that these machine readable files, right, which again are designed for computers to read these, not, and these expectations that the public and the community is going to leverage something out of them, they're not. But it's a matter of how do we take that information and extrapolate it in such a way that all of a sudden the way that you want to say your contracts are modeled versus Evan says his contracts are modeled, and to normalize that and to produce files that are going to be meaningful. I think it's going to be an interesting first iteration of these new files and what can actually be done with them.
Well, I guess I'm going to steal a thunder here on Daniel. So that just basically says pricing transparency really is what the government intended it to be, and the complexity that they've now put onto the health systems and from a provider perspective really is not meeting the intent of being transparent to the patient then.
I would agree. I mean, it's you have two sections of the requirements where, like in 180.5, it talks about the machine readable files, and then 180.6 is what it was trying to tee up in terms of what's supposed to be consumer facing, of which a lot of, or most of the providers took the online estimator tool for 300 shoppable. And I think that can still be helpful and meaningful. But at the end of the day, right, you have all this other data that is contained in these machine readable files. And when providers started to initially publish that information, and then CMS said, hey, payers, you need to do that. And then you look at what the payers say the provider is getting reimbursed, and you say you have the provider saying, well, this is what the payer is paying me. In some cases that aligns, in many cases it doesn't. And then that further confuses the patient community as they hear about this, because it doesn't look like the providers and the payers are in alignment, because at the end of the day, they're probably not.
It makes you wonder if we're going to have like 1,000 different versions of these files with 1,000 different interpretations of it. And we're going to put all this work into creating these files, and it makes you wonder, is anybody actually going to ever open them? Not that they can, but or is like a computer going to try to open it, or is it just going to live out there indefinitely? I'd be really curious to have like a follow-up like 6 months later to be like, has there been any value from posting these, and has anybody done anything with this?
I think I mean, and Daniel, to your question, I mean, these files have been posted. It's just now the new calculation portion, right? And they tried this in the past. I mean, the legislation indicated that you needed to say whether it was variable or not variable, and kind of put your math methodology out there as much as you could. Now they're mandating it more so with that component, and many organizations initially took fines. It'll be interesting to see if they do it again. But really, who can take the data is the payers. So you're seeing them downloading these files, and now they are taking that to leverage that for their negotiation with you with the managed care contracting teams. And what's interesting is you're not seeing the health system managed care contracting teams going and pulling the population around them, their competitions files, because they're now fully transparent and doing the same thing to go and say, okay, well, here's where we're sitting at the median, and here's where the outliers are, or are we the outlier? So maybe we need to give a little bit in this component of it to get a better recovery in this component. I mean, that was all what Revenue Integrity used to have to do. I mean, Aundria is our team, my team, your team, Daniel. That's what they would do, is they would go secretly shop to see when they're pricing stuff, where do they fall within the industry outside of California, who has had for at least the last 15 years a mandate that you have to publicly report your entire charge master and all the pricing. So that's where I think, the difference is a little bit in that component, and it had to be more easily readable for using generic terms, for layman's terms, for the patient to be able to actually view it and understand it.
That's so true, Evan. I feel like we've really gone away from the initial ask of making sure that, you don't get that surprise bill, and not just that you don't get that surprise bill, but that you knew it was coming in advance and that you could shop for it. I am really waiting to see payer transparency. And I have found that, the pricing transparency regulations are really just feeding the payers information that we were never required to give them before. And so I don't see this necessarily making the patient's healthcare experience better. I see it actually making our teams grow even more, right? Because we either have to have a vendor to support this operation, or we now have to have new employees to support this operation.
So Travis, as as being a partner that's out there, to Andrea's point right now, like where do you see providers jumping in to enlist outside of just like producing a file or trying to tie it back? Because this all goes back to a patient estimate at some point too. Like that's the other caveat of this, of that transparency. So where do you see people, health plans, starting to not engage with their provider counterparts, but business partners now having to do that? Because I think that's where that business relationship is going to end up going, and trying to have to be a middleman in some cases too.
I think part of it is that we look at this as like, do we have to come in and help augment, in terms of sometimes it's just bandwidth. And other times it could be expertise, right? I mean, if you have a revenue integrity group, right, that has access and understanding to their contracts with the payers, that's one thing, right? And and not everyone actually has access to that, right? And so I think what has caught a lot of providers flat-footed is that, they look at these payer contracts, and they can't really decipher them because they never really have. And so I think that's why when people were offering up solutions to machine readable files based on historical data, right, that was kind of the easy button, but it wasn't always comprehensive. Now, when you say I've got to crack open these contracts and understand them, and a lot of people look at that and says, I don't have the expertise, I don't have the time to do that. So they need help in order to extract that. And so I think that there are partners out there coming at this from the charge master perspective. There are partners coming at this from a contract modeling perspective, and still some who are still trying to look at the new requirements from a historical data perspective. I don't know that can ever get across the finish line. I think you have to actually combine all three of those in order to do this. And if you've got a lot of what I call the talent and the technology internally, then I think that they can address these. But I think oftentimes it's one of those two that they just need more bandwidth or they need some support because they don't have it.
And can we talk about contracts for a second? I don't think most folks out there, unless they're in the revenue cycle world, and maybe like you said, Travis, not even then, I don't think we realize that you might have a 10-year-old original contract that has an addendum every couple years, and that's a piece of paper or two that doesn't respell the entire thing out. So I think in our system, it has definitely been a little bit more, challenging, and we've had to streamline things quite a bit and work with vendor partners to do so in order to just even have access to, the original contract that actually spells out exactly what their responsibilities are.
Well, I think it gets down to that payer complexity of that contract too, right? All the carve outs that you're going to have and all of those different elements around pharmacy, hospital-based providers versus freestanding providers, et cetera.
Well, and the thing that I also realized in having some of these conversations about contracting with providers is that they'll come into it looking at their contracts, and especially if they have a lot of work done around reimbursement or creating a calculated expected reimbursement, is that the machine readable file answer, was like, the reality of applying a contract is that very rarely, unless it's radiology and pathology or some very singular services, that's the happy path. The complexity of contracts and calculating reimbursement is that you have multiple procedures that are being done and some that are being, disallowed, or, there's multiple procedure discounts. That type of functionality then doesn't really make it through, nor is it translated in the machine readable file, right? I mean, I'm a little bit out there and saying that I think a lot of the machine readable file data that is being out there and circulated, I think it's fool's gold because it really doesn't help providers evaluate each other's contracts efficiently. And by no means is it really helping the patient community, because, just because you see a number associated with a procedure, it's like, how often is that procedure really done by itself? And that's the actual reimbursement. I think you're setting a false expectation.
Mm-hmm.
Evan, any other thoughts on that before I pivot us to another question here?
No.
Cool. So just reading here from our call sheet here and thinking about pricing transparency and its impact on other areas of healthcare. Curious if y'all have insight or thoughts on like professional services, pharmacies, maybe suppliers, just in the impact on when we put all this pricing data out there, how that's going to impact their day-to-day or what their business looks like.
I could think about pricing transparency from provider versus payer, right? The provider approach really has been hospital focused, right? So the physician community, has not had to answer this call And I think as hard as it is for hospitals to do it, I think it'd be almost impossible for the physicians, because I don't think they even have a clue half the time about what their reimbursement really is. Sometimes they just accept whatever they got paid. Where if you look at the payer side of it and their machine readable files, they have been set to a higher standard, and they're supposed to be providing everything, which is not just hospitals, surgical centers, but also including the physicians, so that theirs is a lot more comprehensive. And I think what's interesting is how we look at the onus that's been put on the hospital community to deliver price transparency. There's a gap in terms of what to expect for all of the physicians that aren't associated to hospitals and wouldn't be included in that data. But there's a great deal of data to be had, to where now all of a sudden I think the focus gets turned to the payer MRFs, because the payer MRFs now have that information, but now you have that professional community who doesn't know if that's right or wrong. And so again, I think it creates some more confusion in the industry, because there's no way to counteract it to know if it's right, wrong, or indifferent.
I think that's so true, Travis. I think it's probably going to be a very divisive situation, especially for individual provider practices out there in the community, rural health organizations who don't have the funding to go out there and, work with a vendor provider. And I think that it's quite frankly going to be harmful for these smaller groups, because they won't have all of that connection necessarily that we have been having over the last few years. So I feel very concerned, on behalf of some of our smaller community providers out there.
Travis, I like the point you made about professional services. Like when it comes to like reimbursement for them, they just sort of take what they get, and that's just like the world they live in. And part of it's a resourcing standpoint probably, or like if I'm a provider, I'm also not my reimbursement and my contract and everything else that goes into that sort of shop, but at least if it's standalone. But yeah, no, it'll be interesting to see how that plays out. Evan, sorry, I cut you off there for a second.
No. I was just gonna kind of add to that as well, especially as more providers, we're seeing less and less freestanding providers, and we're seeing them become part of integrated health systems. Those health systems are treating them just as they are in a hospital setting and capacity. So they're fighting every denial. They're going for every dollar that matters. They are giving administrative time to the providers now as well to help write clinical appeals and do peer-to-peer reviews and all of these components. It will be interesting to see how soon all of a sudden pricing transparency hits, because there are major health systems who are like, you know what, we're just we're gonna publish our professional fees now too. We're not even gonna we're gonna try to stay ahead of it and just get it done, versus trying to have to wait it out and have a waiting game. They're already pre-planning for that to be kind of 2025 2026 proposed rules coming out, and trying to figure out how they're going to address that. I think where the caveat plays in is the pharmaceutical and 340B reimbursement and the legislation on there, but also already having to be more transparent in that capacity. I gotta take us to a quick break, but I wanted to get you guys as one last final thought from each of you guys on pricing transparency.
I think my final thought is that there's, July 1 is really just going to be the first iteration of this. And I think there are still a lot of questions, how it's going to ultimately play out. I think part of July 1 is also going to take us a step backwards in some aspects, because they're delaying a field in there, which is called expected allowable, which really is kind of what we're presenting today, or the expectation is. And that's delayed until January. But then the other thing, and Evan, you brought this up when you just said pharmacy, there's an element of it where, the pharmacy transparency, one of the other big challenges with all this is that we don't have a national normalized pharmacy code set that is normalized based off of dosages and units, right? And so when we go to create that, I think, there's a lot of people waiting to say, well, what's going to be the story in terms of how pharmacy is going to be reported, because the way each hospital and their charge master wants to call that out can be very unique. And I think that's going to be one of the other challenges to come.
Well, I know that's going to keep me up at night, Travis. Probably well past the summer and into the next few years. I'll be really interested to see, what CMS comes out with this coming summer as maybe an update for 2025.
Perfect. Well, let's take a quick break and we'll be right back.
Vine Medical serves a growing base of more than 800 active hospitals and health systems nationwide. Their best practices are hardwired through technology solutions, proven to help hospitals achieve sustainable top performance. Their well-published results include improving financial performance, physician and staff alignment, patient experience, compliance, and patient safety and quality measures. Learn more at vinemedical.com. That's VYNE medical.com.
The No Surprises Act requires hospitals to provide a complete self-pay good faith estimate for all providers involved in a patient's procedure, even if the providers are not owned or managed by the health system. The challenge is how to efficiently request estimates from independent providers, how to hold everyone accountable for their contribution, and how to provide a complete good faith estimate within the 24 to 72 hour delivery requirement. At Collective Health, we believe the solution is an agnostic portal where providers collaborate and share estimates while having visibility and accountability to each other. The Hyve GFE Exchange is the industry's only solution that brings together estimates from individual providers into one consolidated GFE. CMS may have delayed enforcement, but is your hospital prepared for a comprehensive GFE? Don't delay. Join the collective. For more information, go to goodfaithestimate.com.
And we're back.
All right, let's transition to the lab, and just want to ask our first question here. So Travis, curious, what drove you to work in the healthcare industry?
Oh, geez. I got into healthcare by mistake. I'm an engineer, electrical engineer with an MBA, and I never in my wildest dreams thought I would be in healthcare. But it was this opportunity that just fell in my lap, about trying to, figure out what a patient is going to owe at it before the time of service, which then translated into pioneering patient estimation 20 years ago. And, then you get into it, it's like, this is such a fulfilling industry. There is so much opportunity, right? I say, if there's any industry that is ripe for help, it's healthcare. Healthcare is kind of wrought with challenges, and they continue to come about. So I think it's a great industry to work in.
We hear that I fell into healthcare by mistake way too often here on this podcast. Aundria, what about you? How did you get into the healthcare industry?
I'm only laughing because I think everybody fell into healthcare. I always laugh at my daughter who's now in college, and I like to say to her, nobody ever grew up wanting to be a revenue cycle leader. But I also stumbled my way into healthcare. My old future was going to be an educator, and I really have always enjoyed helping people. So I went from wanting to be a Montessori teacher to being an OHSU leader, and I actually still get to help people. And so I think that that's the best part of healthcare, and particularly in my field of Rev Integrity, as you know, it's just fascinating that there's never a dull moment. I never do the same thing twice most of the time. If you want to be kept on your toes all the time, maybe a couple sleepless nights on occasion, I think it's a really great career.
Well, speaking of careers, so to wrap up our questions for you guys today, what's one piece of advice you would offer our listeners who might be early in their career or new to a revenue cycle career or IT?
I have to steal the line from Ted Lasso, right? Be curious. I mean, I think that's because when I got into healthcare, right, you like this industry can't be this jacked up, but it is. And you start asking why, right? It's the old adage, you ask why 5 times to get to the root cause of something. And when we were looking at patient estimation and everyone was telling us that it was so impossible to do, you just ask why. Well, it's because the contracts are over here. You can't have access to the contracts. So why? And then, I mean, you drill down and you find out what the root cause is. And at least for patient estimation is because all this data was just disintermediated. And if you bring it together at the right time, you could actually say this is what a patient is going to owe. So I think that I also have this premise that there's a lot of what I call learned helplessness in healthcare because people don't ask why a lot. I think we need to be curious and start questioning why things aren't done. I mean, even back to the conversation around payer scorecard. I mean, it was 18 months ago that I went and found payerscorecard.com was a URL, as a website that you could buy. Like, we've been talking about this for a decade. Why hasn't someone already purchased that? So be curious. I mean, and don't take no for an answer, at least ask why 4 more times.
I'm gonna have a different lens here. I'm gonna go away from my revenue cycle lens, and I would say just a piece of advice for any early careerist is stay open, stay flexible. You might not have wanted to be a revenue cycle leader, right? But it fell into your lap for a reason, and I think that in any sort of leadership position or any relationship in life, it's all about being an excellent listener, asking questions, and knowing that change is coming. We can't stop that change. It's coming. And at the end of the day, you still have to kind of go do the rest of your life and let go. And so I think just having maybe a more relaxed approach to a career, it seems a little bit easier for me anyway.
That's solid advice.
I always hear good stories about people who are flexible or willing to take on change. Like, just even folks I was just working with went from a coding to revenue integrity team. Like, I'm having a blast now. Like, who would have thought that like switching careers almost in a sense would be so fun? But I hear about that all the time from folks. But thanks for joining us to talk about price transparency and payer accountability. I know I have some more research to do on this topic, and I hope that anybody who's listening probably is preparing for 7-1 and everything that goes about with that. But for folks who want to reach out, connect, maybe have questions or conversations, what's the best medium to get in touch with you? And Aundria, you want to start us out?
Sure. You can find me on LinkedIn. I am Aundria Mazoros. And you can also email me, and I'm at Mazoros, Mazoros, at ohsu.edu. And thank you.
Yeah, same thing. LinkedIn, Travis Gentry, or Travis.Gentry at Hyve, Hyve with a Y, healthcare.com. And or if anything else, just go to payerscorecard.com and you'll be able to find me that way.
Well, thank you both for joining us again. We will definitely have to have you both back on as this continues to unfold from a CMS saga. So that's it for us today. Bye-bye, listeners.
If you liked today's episode, continue to join Wilshire Wednesdays.
You can follow us on LinkedIn or Twitter at Evan_Wilshire. Daniel can be followed at Daniel_TWG. Wilshire Group at TWG Health. On Facebook at The Wilshire Group, or on Instagram at Wilshire IT Revcast.
Remember, if you prefer to watch, come check us out at the Wilshire IT Revcast YouTube channel.
If you have an inquiry, want to share your thoughts, or get additional information on today's episode, email us at WilshirePodcast@thewilshiregroup.net.
The best way to support this podcast is to review, rate, and subscribe. See you next time.
Bye-bye.
The Wilshire IT Revcast is hosted, produced, and engineered by Evan Martin and Daniel Bianchini. It is executive produced by Gretchen Case, Hank Smither, and Spencer Thielman. The Wilshire Group. Experience you can trust, results you can count on.